It's good. I am crazy busy this week. I haven't been able to say that in a few months, but went from 0 projects to 1 project to 2 projects real quick. Um, I don't know if you've like heard Mamma Mia or seen Mamma Mia, but it's like Sophie goes from having no fathers, wait 20 years and has 3 fathers. I feel similar to that. How are you doing?
I'm doing all right. Sorry I gave you 2 projects. I am the culprit that caused that problem for him. Well, I'm doing all right. Feeling like it's a Monday, but we're recording on a Tuesday. I'll probably be like you, working the midnight hours to get everything done, but that's all right. Uh, so we'll jump in. So today's episode, we're exploring more about AI and talking through some of those components and getting to jump right back in and do some fun topics that we've been discussing all year long. So excited for today's episode.
Same, and I apologize if you heard the ding. I just got like the new email set up and it's throwing me notifications, and I'm like, I need to turn that off. I'm glad that we have time to jump into today's podcast and we have time for podcasting. This is this first one in a little bit. So I'll go ahead and introduce our first guest if that's all right.
Sounds
All
great.
right. All right, so we have just one guest today, which I feel like has been a trend for us lately. But with over 25 years of experience in healthcare IT, revenue cycle management, all sorts of things, is currently a practicing emergency physician and has focused their career on healthcare provider adoption of new technologies to improve the quality of care, enhance patient safety, and reduce the cost of care, and is an entrepreneur who has launched multiple successful companies. So it's really exciting to have here and get their ideas on the podcast. Currently, the co-founder and chief medical officer of Milagro, which is an innovative platform solution that utilizes AI to provide autonomous coding for surgical procedures, fully autonomous. And thanks for joining us, Dr. Greg Hobbs.
Hey guys, thanks for having me on.
Cool. I know we've been talking a lot about AI, so it's really fun to continue these conversations and just like coding solutions. And in a recent episode, we went into depth about denial management and prevention. It's been a constant theme on the podcast. And Greg, what are some of the biggest concerns you hear from your provider colleagues just on those topics?
Yeah, surgical coding is the most difficult and complicated area of medical coding. And hospitals and providers really struggle to find qualified, specific, specialty specific coders that can accurately code the work. And then there's a real challenge because of that with coding accuracy, which results in undercoding, which, as you know, can leave a lot of dollars on the table. And then there's the issue of denials, particularly pre-authorization denials. So if a patient has pre-authorization for, let's say, procedure X, and then out of clinical necessity, the surgeon performed procedure X plus Y or Z instead of X, many payers will automatically deny that claim. And the provider and the facility as well then never collect on that claim. And this costs hospitals and providers millions of dollars a year. The CFO of a large teaching hospital recently told me that this was their single biggest challenge in denials and that they had no methodology to address it at all.
It's interesting. You're spot on, Greg. Like I was just literally on a call right before this one talking about endo and GI procedures and the dynamic, components of while we're coding procedures correctly based off of what was performed, um, the prior auth component, especially for a surgeon or even a GI doc going in, they don't know if they're going to do it need to do a biopsy or a hot biopsy or a brush scrub until they're actually in there. And health plans aren't necessarily wanting you to get authorization for the entire CPT code range for colonoscopy, right?
Right.
But at the same time, we don't have great mechanisms to do that retro auth component. And even will the health plan even allow a retro auth? We're seeing more and more of the big commercial payers come back and say, no, we don't do retro authorizations just because you did a different approach or ended up doing a different procedure in general
Yeah,
once you got
yeah. No,
in.
I was just talking with the director of revenue cycle for a large health system, and what she told me was that they have almost zero success in getting reauthorization on these cases. So in the GI example, they get pre-authorization for a screening colonoscopy, but you get in there and there are polyps, right? Well, they're not going to reschedule you to come back to get that. They're going to deal with that while they're there. It's the right thing to do for the patient. But then now that case gets denied. And by the time they get the case coded, several days have passed. Maybe the bill has already been sent to the claim has already been filed. And at that point, the payers won't even talk to them about it. So you have a very short window, typically day of surgery, maybe one more day if you want to try to get these things reauthorized. But that requires you to be able to code the case in near real time, which no one can currently do.
Yeah. And and then on top of it, a provider is back to back. So even them being able to finish up their brief op note with enough context for a coder to go and say, "Hey, we have a code mismatch now. Can you do this?" We're just not able to hit those time frames. So I think those are things that we're definitely going to have to address. Spinning it a little bit differently, we also have seen through our conversations with in previous episodes a large move of providers moving into the tech space and giving more of their support and development of technology bases, trying to one, prevent denials, or two, enhance operational workflows so that they can see more patients with less time. We know more and more. I know when I went to the doctor last week, it was a 15-minute visit is what it was scheduled for, and I needed 30 minutes for my medication reconciliation alone before they even talked about everything else. So,
Yeah.
we're definitely seeing providers trying to jump into the technology space to expedite and be able to leverage. What are some areas of technology advancement in the use of AI that you're seeing providers really trying to start to carve to support their clinical operations beyond kind of the coding realm and sphere of things?
Yeah, AI has become a critical element of any new tech solution in healthcare. And to be competitive, any new product has to effectively leverage AI. So we're seeing AI very effectively used to improve workflows, as an example, in ORs and adjust staffing appropriately. We're seeing some very innovative uses of it to capture physician and patient interactions. So you're talking about your patient, your visit with your doctor where he spends all the time on the computer instead of talking to you. AI is able to allow him to capture the entire conversation and auto-generate a note that's more complete, more accurate, done in real time without the doctor having to type or dictate anything. And so they can really focus more on the care. Of course, the area that I'm most excited about is the use of AI for fully autonomous coding. This is a bigger challenge because there are risks associated with using AI, particularly in coding. So physicians, providers are legally responsible for the coding of the care they provide, even though we're actually almost completely blind to the process of coding and we don't even see what was coded most of the time. We're still legally, it's a felony if you do it wrong. And so there's a lot of sensitivity around that, as you would imagine, and hospitals, health systems have recently faced some large lawsuits over fraudulent coding. And so if you're going to use AI for coding, there's some rules. Number one, you have to be at least 95% accurate, which is probably better than the current manual coding is able to do. You have to be able to code most of the cases, so you can't just cherry pick the easy ones and do them and then leave all the hard ones. You've got to be able to cover 80, 85% of all of the cases. And you have to be fully transparent. So That's the problem for black box AI solutions where data goes in and answer comes out, but you can't really see where the answer came from, right? The solution has to be fully transparent to coders, auditors, payers, and to the providers if they want to look at it as well. And so that's where Milagro is fundamentally different. We're a data abstraction platform that leverages AI in the multiple engines that we've developed and enables us to, in near real time, code 85% of all surgical cases with above 95% accuracy with an interface that is fully transparent and shows the coder or auditor exactly where every data element that supports each code came from the documentation.
I think you've set the stage well for there is an element of autonomous coding that is going to be replacing coders or at least assisting coders. And we have an element that I think you mentioned like 85%. You're not cherry picking at this point. You're doing the hard work. And we talked a little bit earlier about the setting the stage of like the reauth situation and AI getting plugged in there. Um, for the 15% or the AI getting involved in reading documentation, any other like comments that you have for our readers or where you maybe think this is going or um, what those conversations are looking like when you're talking with other health plans about these solutions?
Yeah, so the health plans are very excited about it because it is addressing some very acute needs for them. So what we're doing in terms of their coders is we're allowing them to retain their very best coders and reassign those to the complex cases, the really high dollar cases, focus on backlogs in some areas that they have, and then over time, primarily through attrition, reduce the total number of coders that they have. In terms of the mismatch denials, we are uniquely able to take the initial brief operative note that's done right after surgery, and we know what was pre-authorized, what CPT code was pre-authorized. We can tell from the brief note what CPT codes were performed, identify that mismatch, day of surgery, and then automatically push that back to the scheduling team who's responsible for the pre-authorization, enabling them to then reach out to the payer in a time frame that's acceptable to the payer, get that case reauthorized. And so in the clients that we're doing this with, we've almost completely eliminated their mismatch denials.
Perfect. Thanks, Greg, for that brief overview of kind of what you guys are doing and associated with autonomous coding. We're going to dive into that a little bit here after a break, and we'll be right back.
At ValueWare, we help healthcare organizations streamline prior authorization submissions with one platform, helping you simplify, connect, integrate, and automate each part of the process. We take your pre-existing workflow and truly automate it, including the submission and verification process. The best part? ValueWare automates your prior authorization processes for all of your payers, specialties, and service lines, not just some of them. Valor is built around you. Learn more at valueware.com. That's valueware.com.
Welcome to Advocacia, where we make enrollments easy. Our technology is built to superpower your team, providing a more consumer-friendly approach to enrollments into programs like Medicaid, charity care, and SDOH programs. Our tool integrates with your system to pull over data that auto-populates in the background, allows for screening for multiple programs, automated outreach campaigns, self-service tools, and e-signature and document capture. In the background, we're auto-populating forms, making your life easier. If you'd like to learn more, please reach out to Ben Bartholomew. Thank you.
And we're back.
All right. So jumping into the debate section for our listeners who know the cadence of our of our podcast by now. And so in this segment, we talk about industry trends, out of the box ideas, and other things that get you thinking. And Greg, I mean, you're a founder, you're a co-founder, and you founded Milagro. And how did you get this company and this idea to move into the autonomous coding space? Like, what was the inspiration or light bulb moment for you? You're like, I want to be working on this.
We built our technology in Israel, and we set out to build a data extraction platform that could be used to auto-generate AI predictive algorithms. And we were approached by Asuda Health in Israel, which is a large private surgical health system in Israel. And if you're not aware, Israel is one of the top 5 rated healthcare systems in the world in terms of quality of care. And so this is a very sophisticated private health system that consists of surgical hospitals and ambulatory surgery centers. They use the same codes that we use here in the US. They approached us and said, hey, can you guys automate our coding? They had the same problems that we have here. They couldn't find coders. Coders were expensive. They had a lot of turnover. They were concerned about accuracy and cost. They were way behind on their coding. And so we said, let's give it a try, because we had been working in a space that was that involved infectious disease and surveillance for hospital-acquired infections right about the time that COVID hit. And so all of our customers went away. They were completely consumed with COVID. And so we needed to find something that was more compelling. And as hospitals came out of COVID, we found that they were really only interested in new solutions that had a clear ROI. And so this was an area that I felt we could really differentiate ourselves and make a quick impact in the US if we could get this to work. So we gave it a try. Asuda does over 100,000 cases a year across all medical surgical specialties. We not only were able to do the coding, but we significantly exceeded their expectations. We were able to code 85% of all their cases at above 95% accuracy in near real time, enabling them to reduce the total number of coders they have by 90%. Additionally, we corrected downcoding with our improved accuracy, which they told us resulted in a 17% increase in their revenue year over year. So with that success, we said, all right, let's bring this to the US, which is what we're now doing.
Hey, Greg, with that, we're definitely seeing, a shift of clients shifting coders once their organizations have implemented autonomous coding. I know in the Portland metro market that I'm in, almost every major health system currently has some form of autonomous coding in a subset of their area, right? Some are specializing in ED, some are specializing like you more in that surgical space, things of that nature. But with that, I've also seen them shift their coders versus even leverage it, not even just shifting in coding work, but shifting them to other areas of the revenue cycle, CDI, things of that nature.
Right.
Are you seeing that more of a shift coming out of that, where you said they were able to reduce 90% of their workforce? If you're the larger employer in that workforce area, that doesn't go over well, right? With your community of like a mass layoff or even that, or even through retention in that capacity. I think the US market's a little bit different because we've struggled to even have enough coders to be able to perform and get through the volumes that we have. But what are you seeing as a shift in kind of the US market industry of people leveraging this knowledge, because we don't want to lose that knowledge as we're rolling out platforms like
right. No, and that's an important point, because in the US, a lot of times a community hospital is one of the 2 or 3 largest employers for that community, and so they're very sensitive to this. The reality is that they're not firing a bunch of coders, right? They are able to reassign them to other tasks. And then the reduction is more through attrition. But you also have to understand that increasingly hospitals and health systems have outsourced their coding. So the coders don't live in Portland. They live somewhere in India uh, or South America or the Caribbean. And so not only is that coding more expensive than a local coder, and certainly way more expensive than autonomous coding, but there's no impact on their community. And so those are costs that they're happy to get rid of.
Evan, I think it's really just a sidetrack us, take us on a little tangent here for a second. Like you and I are both working in revenue integrity, and I love when I get a revenue integrity person with a coding background. And my fear is like 20 years down the line, all my coders have have been replaced by automation. I don't have people to source with that coding knowledge. So it'll be interesting to see how this plays out over the next year,
Yeah,
5 years,
and,
10
and we're
years.
not, and we're not going to replace all of them, right?
Mm-hmm.
There are, we're doing 80 to 85% of cases, right? But there are cases where they're rarely done, complex cases that are rarely done, that we don't have enough cases to develop and validate an algorithm. There are cases that are inadequately documented, right? There are key elements missing from the documentation. Those have to be kicked back to the coder, who can then go and talk to the surgeon, as an example, and see if that, if there's some coding improvement that can be done. And there are, there are certain, very high dollar cases where a health system would want to always lay eyes on that. Um, and so we see an ongoing role for coders, but what we believe is that what you will see are very highly trained, specialty focused coders.
And I know our next question here, I'm going to try to spin this a little bit just to make it relevant to our conversation here. We were talking about like limiting the number of automated solutions. Or do you see people using like duplicative solutions like autonomous coding for emergency room versus procedure areas? Like, Greg, like, what's your thoughts on this? Like, I know that like your technology, I'm sure, is going to be looking very different in 12 months than it looks today. And I'm curious, like, how are you thinking about that if you were in the provider shoes?
Yeah, no, that's a really good point. So the providers, hospitals, health systems are our main targets. They're looking for single solution. They want one vendor that they can have a long-term partnership with, that can meet needs across multiple areas. They don't want to try to manage 5 or 6 different vendors with all the different problems that come with that. So 6 months from now, right now we're focused on surgical coding, but 6 months from now we will have E&M coding market ready. Very soon after that, we'll have emergency department coding market ready, followed by radiology coding market ready. All of that within the next 12 months. And so we're really seeking to be a single solution that hospitals, health systems can work with and trust to be here for a long time and meet their needs.
So thinking of what you're going to expand, like what is kind of that next hot area? Because you're doing surgery right now.
Yeah.
Are you pivoting to do more like hybrid IR cases, looking at GI endo? And then how are you staying up with like the EMR systems as well? Because at the same time, I know, for instance, and Daniel and a lot of the Wilshire clients are Epic-based clients, and we know Epic's currently building out some form of autonomous coding. It's and I use loosely some form of autonomous coding for their professional side of the house, which doesn't necessarily translate over to the hospital portion of the technical component of the claim. But how are you looking at that integration model with those EMRs to be able to maintain kind of keeping that support in your targeted areas of your company growth versus looking at it from a perspective of, hey, we're going to try to disrupt the entire portion of the industry?
Yeah, so that's a lot of questions. Let me see if I can break it down a little bit. So the first thing is that the next thing we're going to do is E&M coding, right? Because So we're working with Tampa General as an example, right? They do close to 100,000 surgical cases a year, right? But they have almost 700,000 provider visits a year, right? So E&M coding is a big deal just from a volume standpoint. Now, we very cleverly, maybe, decided to start with the single hardest area of coding, right? We actually did that intentionally because we felt that if we could do that, then moving to the areas like E&M coding, emergency department, radiology, those are significantly easier cases to code, significantly less complex. And so we are confident that our technology can very easily handle that. We've built the technology in such a way that it's very easy to adapt to new changes in rules and regulations, right? We don't have to retrain our algorithms and get a bunch of data and update our algorithms. Our algorithms get automatically updated as new regulations come out. It's seamless to the customer, to our partner. In terms of EHR, we have to be able to work with a variety of EHRs. So we spent a long time as we were developing the platform on integration, being able to very easily collect data from an EHR system and push results back in. So we've been doing that with Epic for a long time. And we have Epic integration that is very easy and allows us to capture whatever information we need and push it back into Epic billing. We can do the same thing with Meditech. We're working with an outpatient ambulatory surgery center group that uses a different EHR that's specific for that market. We've been able to integrate with it without difficulty. In Israel, we've actually integrated with about a dozen different homegrown EHRs. So that integration piece is critical, and it's something that we have invested a lot in to be very good at.
I think E&Ms is like an autonomous coding solution would be interesting. I know like Epic has like simple visit coding, for example, that like just pushes from the provider orders, but it would be interesting to see like what role and maybe increased accuracy you can get with an AI tool that you just don't get from the very simple basic solutions that exist today.
Yeah, they changed the rules for E&M. They changed the rules for E&M coding last year. And it went from, how many of these things did you do? How many of these questions did you ask? How many of these body parts did you examine? And how complex was the diagnosis, to now being much more based on complexity of care. And who did you talk to, and what documents did you look at and review, et cetera. And so it shifted from coding that was based on mostly structured data, where you could check boxes and do your documentation, to now really a lot of free text. Turns out that free text is really our secret sauce. That's our strong point, our key differentiator. It's why we're able to do surgical coding so well, because we're taking a fully text note, the operative note, and using that to do our coding. So we can apply that to E&M coding, and the emergency department actually now uses the same E&M coding rules as an office visit does. And so for the provider, they have different rules for the facility, but for the provider. And so I think we'll be able to very easily move into those areas, and we're already working on it and showing good success.
Greg, how do you think the health plans are going to respond to E&Ms? Because we know, like, in the emergency room, just for instance, right, like we see a lot of down coding on level 4s and 5s. They're citing it's a bell curve component and everything. But with that said, not all the health plans are also, I mean, CMS is very clear. You just have to have a standard, your organization standard. There isn't a set industry standard out there. So how do you see that playing out in autonomous coding for E&M and like in the ED, for instance, and
Yeah.
how that's going to affect with the health plans?
Yeah. Yeah. So there is a lot of turmoil in emergency department coding right now. Uh, there's a couple of very large physician provider groups, national groups that dominate emergency medicine. They are constantly in court, either being sued or suing payers because they believe that they're being underpaid, or the payer believes that they're overbilling. And so this is a very contentious area. The key to this is consistent accuracy and transparency in how it's being done. And I believe that if you can show the payers the algorithms that are being used and how they're following the rules and how they are consistently only coding what is documented, that yeah, that situation can be significantly improved. I do believe that well, I'm an ER doctor, so I'm going to fall on the side of we're getting underpaid. Um, but I do think that the burden falls to us to make sure that not only are we accurately documenting what we do, but that our coders are reading all of that documentation and accurately coding, right? A fully autonomous solution like Milagro always reads everything, and we're able to understand it. And so we can provide the consistency that I think is missing now.
In a way, it's a black box, but it's also not a black box because, yeah, to your point, it's consistency. You're always going to have the same results if you have the same inputs, and there's
Exactly.
there's a, there's a level of comfort, I guess, when you think about like these tools, these AI tools getting stood up, that over
Well, you
time,
know,
like,
yeah, I mean, I was on a call just yesterday with a large health system in Texas, and asking them what their problems were, and they said, well, we get different codes depending on who's coding the case, right? Same surgeon, same note. They send it to three different coders and get three different results. And so they were really looking for that consistent high degree accuracy.
Yeah. I think it's definitely, I love that you guys are able to take that full written component and really come out of it versus looking for technical charges triggered by the hospital and then comparing it against and doing that contrast. I think when we do that, there is that level of like, how are you coming up with this, and looking at it. And with some other of the partners, it really comes down to business partners out there. I think that's why they have those senior coders that have been around the block long enough, going back and auditing and looking at it to say, do we agree, do we not agree, on a constant basis. With it, what are other, like, just general black box kind of out there solutions, looking at it from that perspective? What are those things as our listeners are thinking to start evaluating, like, who do we want to engage with, how do we want to engage in autonomous coding, kind of those key things that you would think from your perspective as from a provider lens? What are the things that you're looking at for your help, as if you were to assess them?
Yeah. So I've been in that position in the past. I was a medical school department chairman for 12 years and ran emergency medicine for a very large health system in Texas. And so, we were looking at new technologies all the time, right? So what they have to look for, and and I was discussing this actually just last week with one of the, and I won't name names, but one of the large scoring uh, companies out there that sort of, rates and ranks and evaluates technologies. And they had done some research on this, and they said that, the baseline criteria was that you had to be consistently 95% accurate, right? And that you had to cover at least 80% of cases. And so you can't just cherry pick the easy cases and say, we're 100% accurate. Yeah, but you're only doing 30% of the cases, right? And you have to be fully accurate, right? So on surgical coding, you might have 3 different CPT codes, 2 or 3 different surgeons and an anesthesiologist that you're coding for, have different modifiers, different ICD codes. And to be accurate, let's say there are 9 of those, getting 8 out of 9 counts as 0. You have to get 9 out of 9 to be accurate. And so, it's a real challenge. What most companies who say they're doing autonomous coding are really doing what I refer to as automated coding. In other words, they're providing assistance to the coder. They're making the coder more efficient. They're doing some of the coder's work for them, showing it to them so that the coder can then more easily, efficiently review that and maybe more accurately code the case, right? And so that's what's mostly in the market if you look at what most of the vendors are offering. We're fundamentally different than that. We replace the coder if they want them to be replaced. If they don't, they can use our system for the coder to look at it. It's fully coded. They can see the text that's highlighted, color-coded for each code and see how it was coded and approve it. We provide them the flexibility to do things like, we want the coder to look at all of Dr. Hobbs's surgeries, right? So because we've had problems with him or whatever, and so we can do that. We can code them and then we kick them to the coder to review. So there's a difference in fully autonomous coding and coding assistance, and we believe that we're the only fully transparent, fully autonomous, real-time coding solution on the market that can currently meet these accuracy and coverage standards.
I can appreciate that. But I know the conversation is going to be continuing for a lot of our health systems. I know Evan and I, we engage with clients in like various interim roles, and we're going to be having those conversations when you're looking at like resourcing and where's coding at. So I know for our listeners as well, I hope you all are having those conversations too. And I mean, Milagro obviously has a lot to offer, and I'm hoping that some folks will maybe be reaching out to you just to assess that, because there is going to be a need. I know we've talked a lot about the autonomous coding piece. I want to get back to the re-auth solutions that you all have as well, just because I want to make sure people understand the full gamut of like what Milagro is offering. And, as they're thinking through, like, maybe I don't have an issue with my coding staff right now, but I have a pressing need on the re-auth issue. How are you framing those conversations with customers, potential clients, about preventing denials on that front?
Yeah, so that's actually how we are leading the discussions with most of our customers and potential customers, because this is a solution that can be very quickly implemented without impacting their coding process, right? They don't have to change anything. We can do a very easy implementation, identify these pre-authorization mismatches, and then push that to whoever they want us to push it to, typically the scheduling team, but if they have somebody else, wherever they want that to go, using just the brief post-operative note, and allow them to address this multi-million-dollar issue. in just a matter of months, be up and running on that. And in the process, we're still we're going to fully code the complete note when it's done. And when all the data is there, sometimes you have to wait on path reports and other things to fully code a case. And so 2 or 3 or sometimes 4 days later, when everything is finally there, we'll fully code those cases for them. They can then begin to use that if they want to. But if they want to just start with addressing denials and then move to autonomous coding down the road, we're wide open to that, because we believe once they see how well we're working, they'll always make that move.
Perfect. Well, let's take a quick break and we'll be right back.
There are thousands of medical offices and facilities across America, each navigating through changing regulations and reimbursement models while striving for positive patient experiences and outcomes. A common element in each of these facilities is patient access, the front line of both the revenue cycle and the patient experience. Though diverse in facility size and geography, patient access professionals unite around a common purpose: enhancing the overall patient experience to increase patient satisfaction and outcomes. Through it all, one organization is there to educate, connect, inform, and pave the way toward the future of patient access. The National Association of Healthcare Access Management recognizes the changing role of patient access professionals and their increased importance.
Claim Capital is a team of ex-Epic staff focused on preventing denials. Instead of showing what was denied, which is the standard for other solutions available today, Claim Capital pinpoints why claims are denied. By training machine learning models on an organization's claim and remittance data, Claim Capital can identify the causes of denials and recommend changes in EHR build or workflows to prevent them from happening in the future. With a completely HIPAA-compliant infrastructure, no software implementations, and a zero-risk pricing structure, organizations can quickly and safely recover lost revenue.
And we're back.
All right, so let's transition to the Wilshire Lab. Greg, just want to get our listeners to know a little bit about you. And first question would be, like, what drove you to work in the healthcare industry? You probably have a unique perspective as more the provider side on the forefront.
Yeah, I went straight from high school to college, college to medical school to residency. So yeah, I always liked science. I liked helping people who were in need or in distress. And so emergency medicine has really been a perfect fit for me with that. Plus, I get bored easily. And so that works out pretty well, too. And early in my practice, I realized that I could have a larger impact if I focused on improving care delivery, care efficiency, patient safety. And so that's how I got into innovation, which has been nice for me. I've been able to continue to practice while I've worked with some really great companies to do some things that I think have had a significant impact on population health.
Greg, as you embark in any of your journeys in your career, what's one thing that you reflect upon that you're like, I wish I would have known that piece of advice you can offer our kind of earlier careerist in the industry, or maybe even making a career change that they should continue to think about?
Yeah, I think, there's a lot of stuff I wish people would have said to me a long time ago. But, I think maybe the most important advice I could give to someone who is thinking about or heading into innovation is pick one really important, really difficult problem, and in an area that you have some degree of expertise, right? Don't head into something that you're not an expert at. And instead of just trying to find a way to incrementally improve the current solution, find a way to fundamentally address the problem differently, to change the way that it's done, making it more efficient, more effective, more cost effective, easier to access, whatever. And stay focused on that one thing. It's very easy to get distracted and, we have a platform solution where we can do a whole bunch of different things, right? We have to stay very focused on coding because that's what's working well for us. And I think it's going to change the market. We're addressing issues that are important, both for patients and providers. And so I think that would be the advice I would give. You also have to be persistent. These things don't happen quickly. It generally takes years of hard work, sacrifice, investment, and you've got to believe that you're doing something important and that you're the guy that can get it done.
I really appreciate that. I can appreciate the focus on like a particular problem as well. I think you see the best solutions are simple ones that address a singular problem versus trying to tackle the world. So very much appreciate it. And thanks for joining us and giving our listeners an overview of, what exists out there in the autonomous coding space and what Milagro has to offer in that sense if they're exploring that. For folks who want to reach out to you, whether it be personally or, engage with Milagro, what's the best way to connect with you?
Yeah. So first off, thank you to you and Evan for having me on. This has been great. I've really enjoyed it. If people want to reach out to me, you can email me at Greg, G-R-E-G-H, at milagroai.com. You can follow me on LinkedIn, or you can go to our website, www.milagro.ai.
Perfect. Well, that's it for us today. Greg, thanks again for joining us. And listeners, we'll talk to you in a few weeks. Bye-bye.
If you liked today's episode, continue to join Wilshire Wednesdays.
You can follow us on LinkedIn or Twitter at Evan_Wilshire. Daniel can be followed at Daniel_TWG. Wilshire Group at TWG Health. On Facebook at the Wilshire Group or on Instagram at Wilshire IT RevCast.
Remember, if you prefer to watch, come check us out at the Wilshire IT RevCast YouTube channel.
If you have an inquiry, want to share your thoughts, or get additional information on today's episode, email us at WilshirePodcast@thewilshiregroup.net.
The best way to support this podcast is to review, rate, and subscribe. See you next time.
Bye-bye.
The Wilshire IT RevCast is hosted, produced, and engineered by Evan Martin and Daniel Bianchini. It is executive produced by Gretchen Case, Hank Smither, and Spencer Thielman. The Wilshire Group. Experience you can trust, results you can count on.